All right, welcome. I am Eryn Price. This is my very first podcast, and I'm so thrilled to have Cathy Ryan here. Cathy literally wrote the textbook on traumatic scar tissue management, and I think it goes really well hand in hand with the work that I do as a massage therapist and the founder of the Mastectomy Guide, where my whole mission is to bring hope to people going through breast and chest surgery through the art and science of massage therapy. And Cathy's textbook, if you haven't got it already, is so well worth the investment because it is really well researched. There it is, traumatic scar tissue management. And I met her first taking her course years ago, which still stands out as one of the best courses that I've taken so far. And then we recently had a chance to reconnect at the RMTBC Rehab Symposium that happened, where I was fortunate enough to be a guest speaker, and Cathy was wonderfully supportive in that venture. And now I'm so thrilled to be here with her, kicking off this podcast venture where we're just going to have a conversation about scars. So, welcome, Cathy. Thank you so much for being here.
Thank you so much, Eryn. Yeah, as I was just saying, I love this. Any opportunity to get together with colleagues and shop talk massage therapy, I'm in. So
Yeah.
thank you so much for inviting me to be your first guest.
Yeah, first guest. You got to start somewhere, and why not start at the
Yeah.
top? Good.
Oh, hey, thanks.
Yeah, seriously. So let's get into some nitty gritty. How did you get into working with scars? Like, why did scars capture your attention to begin with? It's not,
Mm,
massage therapy can go so many different ways.
yeah.
And, how did you get into scar work?
Well, initially, for me, it began in massage therapy school 30 some odd years ago. One of my instructors, Susan Brimner, had spent a bit of time working in one of the burn units in Toronto. So when she came to our school to teach, she was already, into working with scars. And Sue was also one of the first people to teach lymphatic type work as well. So she was starting to do some of the lymphatic stuff and was teaching back in those days. She called it swelling technique.
Mm.
It was an actual term of a technique that was testable at the CMTO back in the day. They didn't call it manual lymphatic drainage. She just called it swelling technique,
Right.
basically for moving fluid out of an area.
Right.
So she taught us that, and I had a few opportunities in student clinic where clients came in with a sprained ankle, whatever, and watched something that looked like a grapefruit reduced to the size of something that looked like a lime, and you could see the demarcation of the bony prominences. So that was just like one of those, like, oh my God,
Yeah.
we are amazing, look what we can do, right? So that just kind of really stuck with me, and Sue was big on the scar stuff, so certainly that began my interest in working with scars. Fast forward many years later, in the probably mid to late 90s, I started to take a real interest in fascia, and in particular started to learn about fibrosis, which is changes in collagen as a result of overuse and injury. And certainly that's part of the whole issue that we're dealing with. We're talking about scars, we're talking about abnormal collagen that is impacting function. So then, as I started to take the deeper dive into the fascia science, fibrosis started to become one of my things. So, I started to put those things together, the lymphatic work and working with fibrosis and, the whole notion that we can break down scars, we can't, and just exploring the science around that through the world of fascia. And then eventually in 2013, I met Nancy Keeney Smith. And then we began the research for the book, and that just drew me further and further and further into the world of scar tissue
Right. So it was sort of an organic process, but the seeds were planted almost right away by the
right
sounds of it.
away, right
Yeah.
away. Yeah.
Yeah, which is really cool. So, what is it about fibrosing that caught your attention that made you realize like this is important to pay attention to?
Well, I think one of the things I was teaching at one of the massage therapy schools in Ontario, like the entry to practice stuff, and my instructor Sue Brimner was still teaching at the time, and we were asked to put together a standardized curriculum for the school. I had an interest in writing, and I loved the writing curriculum part, and Sue was just an amazing instructor, so we were working together on that. And I started to look at all these treatments that we were learning, Achilles tendonitis and, lateral epicondylitis and all these different things. And we had to learn all these protocols for all these different treatments, and I started to think about it physiologically. So, what is it exactly that we're dealing with here? And
Mm,
many of the things like overuse syndromes and all this kind of stuff all started to kind of come back to one place, and that is abnormal changes in collagen.
mm,
So you can call it all these different things, plantar fasciosis and tendinopathy and whatever, but really one of the prominent features of all of those things, and the same thing with scars, is fibrotic collagen.
mm,
So that's really what kind of just got me thinking about, because I'm, from my perspective as an educator, one of my things is if we can understand process, if we can really focus on what is it that's going on
mhm.
that needs to be shifted or changed to help benefit that patient. We can call it whatever we want. I call it my blue shoe, whatever. Yeah, my flu bogs, whatever we want to call it.
At least
Um,
they're stylish.
yeah, but if we really break it down into what is actually going on, then it's much more difficult to stump us when
Mm,
someone comes into our practice presenting with something. We can kind of figure out, okay, this is what's happening in the tissue, so this is what needs to shift, and how can these help facilitate that?
so how do these help facilitate that? What is that magic that happens?
Well, are we talking specifically about fibrosis? How do these
Yeah,
facilitate a change in abnormal collagen?
yeah, yeah, because we're all
Um,
manual therapists, right? So we use our
mhm,
hands. Our hands are our main tools, and sometimes we'll use a third party tool, like I've got a little wooden one, or sometimes people use the Graston
sure.
thing,
Yeah.
whatever.
Yeah.
But our hands are really where the contact is, and so we're touching the skin. We're not really touching the underlying structures. So
Correct.
how are we changing from the skin down to the underlying structures to be able to help affect the collagen, which is gone wonky for using a very technical term.
Yeah. Exactly. Very technical and accurate term. It's gone wonky. Um, a couple things. I think it goes back to some of our massage therapy, education and training. Is one of the things that we can do is have an impact on the nervous system.
Yeah. Hmm.
And then via the nervous system, we'll call it reflex effects, whatever we want to call it, certain shifts or changes happen that sort of facilitate that process. In the world of fascia, one of the big aha moments in 2007 at the first Fascia Congress was integrins. So we have these cell surface receptors that are responsive to mechanical stimulation. So stretching, pushing on, manipulating tissue sends some kind of message to these integrins, and then the integrins send a message into, say, a fibroblast, whatever the cell is that they're sitting on, and then that drives some kind of shift or change.
Right.
So getting into the nitty gritty of physiologically, how can we affect change? Those are kind of, so whether it's the autonomic nervous system that we're having some kind of impact on, or more the peripheral kind of nervous system of sedating or tension, muscular tensional changes or whatever the case may be. So that's the physiology of basically how we actually use our hands does matter. It
Yeah.
really does, because there are certain techniques that are much more effective with respect to calming or sedating the nervous system than other techniques, and there's no one that's better or best.
Hmm.
We have an arsenal of different techniques. I may have a preference for certain things, but that doesn't mean that that is the only or best way to do it. You may have other techniques that are equally or maybe more effective than the techniques that I'm using. And I think that's one of the things that Nancy and I really tried to impress, when we're teaching workshops is, look, we're sitting in a room of massage therapists that have maybe just as many years of experience as we do, and some maybe more in some cases. You all got good hands.
Yeah.
And obviously, you all are really interested in getting the best possible outcomes for your patients, or you wouldn't be here.
Yeah.
Because I would say people that are taking our workshops are not people who are looking to simply fulfill a CE requirement. They're really interested in improving their skill and knowledge so they can get better patient outcomes. So you all got good hands. You know what you're doing. You know how to feel with your hands. You've got that ability to really feel what you're feeling. I would say, particularly in the world of oncology massage therapists interested in that world are also very much people who have the ability to really be present, and develop a really solid therapeutic relationship with their patients. So,
Mm.
though, I think that therapeutic relationship development is every bit as important as what these are doing, in my
Ag-
humble opinion.
Yeah, agreed, agreed. And with the demographic that I work with, who are people, often they're going through breast cancer, sometimes they're going through elective breast surgery, sometimes they're going through transgender top surgery, non-binary top surgery.
Hmm.
Having that kind of genuine therapeutic relationship with your person really sets a tone for them being able to receive a treatment in a way that is far above and beyond just your standard massage therapy. I've got a sore knee, come and rub it kind of experience.
Yeah,
Even somebody who's really orthopedic, but they just don't really connect with their patients, then it just creates a bit of a divide in the healing capacity, I think, that a person can tap into and that the therapist can tap into. So when you're able to create that relationship with somebody and have good hands and know what you're doing, that's where I think the art and the science come together, and you can really create extraordinary treatments for people. And for yourself too, as a therapist, it's gratifying to be able to work with people in a way that feels more meaningful and feels like there's something going on in there that's just beyond what you're doing with your hands. Hand skills are important, of course, but
absolutely.
yeah, the person to person side of it, I think, is also really important.
For sure, knowing your anatomy is important. Understanding the physiology and the process is important. All those things are really important, but I think sometimes we don't give enough credence to the development of the therapeutic relationship and just how important that is.
Mhm.
I think there's a certain percentage of the population that can receive what I would call that very technical orthopedic work and do just fine with that.
Mhm.
Um, but as I've seen over 30 plus years of practice, I think that's a small part of our population because we have so many people who into our practice that we may not know the extent of their history and what kind of trauma they may have experienced over the course of their lifetime. And I'm someone who's very much mindful of differences in nervous system. Not everybody's nervous system is the same. I work with a number of people who, for a variety of reasons, have what I would describe as a more hypersensitized nervous system.
Yeah.
And if they're seeing someone who is not present, not establishing real safety in the treatment space,
Mhm.
not compassionate, in the way that it needs to be, I think they would be hard pressed to kind of get the kind of outcomes you would hope to get in working with that individual.
Yeah, agreed. Because their nervous system, which is already hypervigilant, if they don't feel safe, they're going to be rejecting most things that are coming their way because they're like, alert, alert, danger
Absolutely.
zone. Yeah. And so for them to be able to relax into their treatment, to be able to receive it and to feel safe, then that allows those changes to start happening in their body because they're open to it and they're saying, yes, this is okay. I'm okay here. I'm okay to receive. And, people who've been through trauma, this is a huge thing. It really does carry in the nervous system. And there's wonderful work that's been done showing how wild animals discharge the trauma from their nervous system, and they shake and move and they
Yeah.
do things until their nervous system is like, okay, it's all
Yeah.
out, and then they get up and off they go and they're okay. But we as humans, because we're so trained to be, still, and or intentional movement, like you're working out or doing a sport or something, but that kind of random nervous system discharging, it's not very common in our society. So people end up carrying things in their body for a really long time. And then if they're with a therapist who's not very mindful about treating people who've been through trauma and might do
Hmm.
that unwittingly trigger them, then that person's nervous system, it's already on high
Yeah,
alert. And that's really challenging. So one of the things that I learned in your course, which it was already a focus of mine, and one thing that I appreciated and I've carried through to this day is that kind of less is more approach. It's gentle, it's not aggressive, and it's really tapping into the body's ability to, shift and change itself. So maybe you can speak a little bit more about that, because I know, you use a gentler approach with a lot of your techniques.
I do. And what you were just talking about, Aaron, is exactly why Nancy and I titled the book Traumatic Scar Tissue Management, and not just scar tissue management. And
Mhm.
we do have a whole chapter on trauma, because oftentimes people who have had surgeries, that in and of itself can be a very traumatic experience. And particularly in the world of oncology, you're working with people who are not only gone through maybe some form of extensive surgery, but they've just given probably one of the most challenging diagnoses that we as a human being can receive.
Sure.
There's a lot of fear and a lot of anxiety that comes with, a cancer diagnosis. So that was really important to us. And I mean, with my techniques, yes, I do have a tendency to be more on the conservative, conservative or gentle approach because I work with so many people in my practice who have a hypervigilant nervous system. But that doesn't mean that I don't do, you know, deeper type of work anymore. I do sometimes because there are some individuals whose nervous system respond really well to heavier pressure.
Mhm.
Their body just craves it and they respond well to it. And it's not risky for them. And there are no adverse events that occur as a result of them receiving that, a little bit heavier pressure work. So I do provide that for some clients, when we've discovered that works really good for you. You really like that. And it seems to be productive. So I'm always mindful of what is going to be the most productive way to approach this for this individual. And sometimes it takes a while to sort of for the therapist and the patient to figure that out together. We may not figure that out in one or two sessions. It might take a few to kind of figure out, oh, your tissues, you and your tissues seem to respond well to that. But I do always start on a little bit more on the conservative side. I
Mhm.
would say is typically my approach, and part of that is because in working with scar tissue, for example, I've discovered that you do not have to beat the snot out of the tissue in order to get, when we're talking about, how can these be most effective. One of the things I discovered with fibrosis, for example, is, and my thing is we cannot break this stuff. Collagen has the tensile strength of steel. My hands are strong after 30 plus years of work, but I would not want to have to try to go after somebody in a way to try to break steel in their body. That would be not very nice way to approach a treatment for the patient.
Yeah.
Um, it's not breakable, but it is changeable.
Mm.
So this is where the fascia science came into the mix for me, is understanding, okay, we've got fibrotic collagen. What does that, what does the person's body need? What does that strand of collagen need in order to shift itself into something that's more juicy and pliable and slidey?
Right. Right.
Because that's what we want to happen with this collagen. We want it to become more juicy, pliable, and slidey. And we want to get things moving because getting it moving helps to reduce the number of what I would say unnecessary collagen crosslinks that might inhibit movement.
Right.
And that's something that Robert Slipe talks about quite a bit in his book, Fashion, Sport, and Movement. So I've got some books here to show people.
Oh, yay.
So if you want to know lots about fascia science, from, and he takes more of a sport and movement perspective, but a lot of the fascia science is in this book, and it talks about collagen and what happens to collagen and what's needed to change the collagen. So that's a good resource.
Mhm.
Um, so one of the things, and this also comes from the research of the Steccos in Italy, one of the things that they discovered is that a shearing type of technique is the most productive for improving the the fluid state of collagen.
Right.
So it helps to stimulate fasciocytes, a discovery by Carla Stecco, to release hyaluronin, which is one of those hydrophilic compounds that sucks fluid into the collagen strands, so they become more juicy. And hyaluron is also a lubricant, so then become more slidey. So I employ a lot of what I would call shearing types of techniques with my hands. In the as you know, in the scar tissue stuff that I teach, I do a lot of what I call ballooning or lifting of the tissue and then shearing it. Very different than a friction technique because I mean, the Steckos do a bit of a compression and shear. I have a tendency to do more of a lift and shear.
Mhm.
It's more comfortable
Yeah.
than the Stecco's compression shear, which is quite uncomfortable to say the least. Not to say that it's bad because their work is extremely effective. But if I can figure out a way to get the same outcome and it be more receivable, I'm into that.
Yeah. Yeah, me too. Yeah, and especially people who've been through something really difficult and they have had trauma in their body and they have had, especially with breasts and chests, where it's very like it's very personal. It's very in your face when it's in your chest. It doesn't, the metaphor doesn't necessarily exactly translate, but it's very like noticeable. And if you've been through
Yeah,
something that's really, really personal, it's right here. It's very, painful. You're not enjoying your body. And then you're receiving a treatment, which instead of feeling like, oh my God, this is more uncomfortable. I just want to get away from this. Instead, you're having a treatment where you're like, oh, I love that the thought of ballooning into something where you're like expanding into it and this feeling of like receiving, like opening to it. And then it's not so difficult for your body and it has more of a pleasure response as opposed to gotta get through this
y-
response.
yeah,
And I think that's easier for the body to integrate, for the person to integrate.
yeah. I mean, if you want to set me off, you'll say no pain, no gain. I mean, I just lose. There are a few things that I lose my mind over, and that's, I think, one of the worst terms that could have ever been applied to manual therapy or healthcare in general.
Right.
I mean, I understand that, or, you've just had a knee replacement. It's going to be painful to start moving it. I get it. But as a massage therapist, it's just like, you know what? It's not necessary. I find in my practice to get the outcomes that the patient is looking for, and I know that I'm capable of. So if there's a kinder, gentler, more humane way to go about it, why wouldn't I?
Yeah, for sure. Why not? And
Why
so
not?
much of our body has, compressive forces to it. And, thinking about everything that's happening underneath the skin with scar tissue, it's designed to hold and to, be strong and to keep things in place. And so if you can produce some counteractive effect where you're helping to create some, plumpness in between
Yeah,
the layers and have it so it's not so rigid, it's not holding down, it's still doing its job,
yeah,
it's holding things together, but it's
yeah,
not doing it in such an overbearing way, then I think you'll get a great response from that. Yes?
for sure. And kind of one of the ways that I sometimes will describe it when I'm teaching or talking to clients is like, to a degree, our loose connective tissue that creates these sliding sort of interfaces between these variety of chunks of tissues, it's kind of like a sponge in a way that under a lot of tension, it does not have the capacity to hold the amount of fluid that it typically could. So if we can somehow get the compressive force off of that, it becomes a better, at sucking in some fluid to make it more
Glidey,
juicy.
glidey.
Yeah, exactly. So people say to me, "Oh, I should drink more water." Well, yes, that's part of it. But, again, if I've got a sponge and I squeeze it in my hand, I could stick it in a 50-gallon bucket of water, and that sponge would only be able to uptake so much water because it's being,
Mm,
whereas if I can kind of ease that off, then it's like, oh, I can draw that in now. I can
mhm.
breathe a bit better, and these are some of the terms that clients will, or patients will relay back to me. It's like, oh, it's like my tissue can breathe. Like that feels like you've just taken a 50-pound weight off of, that area or whatever the case may be is kind of sensation that people will often describe when I ask them for some feedback. How does that feel now in your body?
Yeah, nice. And that feeling of compressive force against the chest, against the breast is really common after breast surgery, after radiation
Absolutely.
area, and feeling like, oh, it's just so tight. I just like I can't even take a full breath. It's just so
Yeah.
restricted in through here.
Yeah.
Yeah. So
Yeah.
those
It's like they've
kinds of
been bound. It's like they've been bound with
yes,
something, right?
yes, yes. So, if you can remember back, what was your first experience treating somebody who had gone through breast and chest surgery, whichever type it was? Was it a breast cancer patient? Do you remember?
Yes.
Maybe describe that. What was that like for you?
Wow, that's going back a long time. Just trying to remember. I I think for me, I felt fairly comfortable in seeing that client. Again, this goes back to my education and training. Um, Sue Brimner also was the instructor at our school that came into every class to teach breast massage.
Oh, wow.
And as well, I had taken a course way, 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 way back when with Deborah Curtis and Pam Fitch,
Right,
breast
right.
massage. So they were considered like the who's who of breast massage back in the day. Like we're going back probably 25 years ago.
Oh,
So
amazing.
I felt fairly comfortable, working with the tissue. But I would say at that time, because I was still fairly new in the profession for the most part, um, I felt where I was lacking a bit was just in the therapeutic relationship piece, which is, I think, one of those cases that really prompted me to really start to become more comfortable, in interacting with someone who had just gone through something pretty
Significant.
significant. Yeah, for sure.
Mhm, mhm.
So I think that was one of those moments where it's like, okay, I want to really expand myself in this area so I feel more comfortable on that level. I felt fairly confident with my hands, but I think that's the area that I still felt like I need to, and as well, just the whole oncology thing. Okay, I knew a little bit about it because we get a bit of education and training in our entry to practice stuff, but
Not a
I
lot.
don't think not nearly enough
Mhm,
to
mhm.
really be solid in our capacity to work with oncology patients, which is why I'm so thrilled to see people like yourself and others out there who have taken this on as their focus
Mhm.
because it's an area of real need
Yeah.
in
Yeah.
our world.
Yeah. And like what I've seen so far with my patients is that the medical side in terms of getting your appointment with your surgeon and your oncologist and like that side of it is pretty good, but the other components are very sparse. It's not like nobody's doing the work, but it's not a lot, and it really needs to
Yeah,
be a lot more because
yeah,
in the states 1 in 3 people are affected by breast cancer. In Canada 1 in 8 people are affected by breast cancer. And I mean, in Canada we're this year 2022 28,500 people being diagnosed with breast cancer, and they're going to go through their treatments. They're going to get their chemo, radiation, surgery. Those are our major 3 that we use to attend to cancer, and then they're like, okay, see ya, hope you do well. And a lot of people are like, well, what do I do now? Like, I don't know what to do now. And so if we can broaden the awareness of, okay, there's this whole demographic of people. They're massage therapists. They're trained. They understand how to work with
yeah,
radiated tissue. They understand how to work with the scars from the surgeries. They understand how to work through chemo and radiation and, the changes that happen that way. Then you can be supported in a very human centric way on this whole, like through the process and after, all the years after, because the after years are long, and my patients are often,
absolutely.
yeah, they're unprepared for the length of time that they're still dealing with the layers of um, effect that have happened. So here's a question for you.
Yeah.
Multiple surgeries are very common where
Hmm.
people they get their first surgery, and say they have a lumpectomy, and then they're thinking, okay, this is great, but it turns out actually I'm going to need a mastectomy. And then something happens with the mastectomy, and they're like, okay, now I need a DIEP. And they have multiple surgeries that go on, whether it's because of complications or cancer recurrence or the different types of things. So how do you work with scar tissue in an area where it's had multiple surgeries and it's had multiple incisions, and it's not just a one-off, but it's been repeatedly affected by the surgeons? What do you
Right, right, and I've seen that with C-sections as well.
C-sections for
Right?
sure. Yep.
So that's another potential for, surgeons going in along the same line,
Mhm.
which from their perspective is a good thing to do because then you're not interrupting new tissue each time per se, right? I mean, I really don't approach it any differently than I do of someone who's had a one-off. It really just depends upon, I mean, and everybody's healing process is so different. I mean, although there's the standard stages or phases of wound healing, homeostasis, inflammation, proliferation, remodeling. And there's generalized time frames, and this kind of taps into protocol and timing of when I start and what I do. It really depends upon, okay, what stage is this person in, what's going on, what needs to be supported, um, what do I want to be mindful of to not interfere with? All those things factor into like the protocols, right, of what I do. It depends upon what stage of wound healing they're at, really. And that kind of dictates what these are doing as well. So I really don't find working with the multiple surgical incision sites really different than a one-off,
Right.
because it really kind of depends upon, because some people can have multiple, you know, uh, incisions, and they fare pretty well.
Yeah.
Each time it really was no different than the first time. And then others can have a single, incision and it be problematic.
Mhm.
So it really, there's nothing sort of different or unusual that I do under those circumstances. It really just depends on the presentation.
Presentation. So we had a question from I put out to our Facebook group that I was going to be having this conversation with you, and some of
Yay.
the people, yeah, I know they had some good questions that they
Really
brought
great
up.
question.
So one of them was around this surgical scar that is going from pelvis to xiphoid. And it's got multiple layers of scar tissue. It's surrounding the colon and the organs. At the moment, the patient is not very far past their surgery,
Mm,
9 days past the colon resection, but 12 years since they had a radical hysterectomy. So there's a history of scar tissue in the abdomen. And,
mhm.
obviously you haven't seen this patient to be able to assess
Right,
them, but in
right.
terms of, what you're hearing there, how would you approach that patient?
Yeah, just in general. So again, there's so much complexity of information that we need to assess in order, so I'm not giving a treatment plan for this person because I would want to gather more information. But in general, a couple of things. So, and one I just touched on with regard to protocol. So if this person is, let's say, you know uh, less than 2 weeks out from their surgery, really what I'm focusing on, they're in the inflammation stage because it typically lasts anywhere from a few days to a couple of weeks, typically speaking. So I'm just really focused on trying to support that stage of healing. And trying to prevent excessive uh, lymph stasis. So trying to encourage things to keep moving.
Yeah,
So lymphatic work is really important
yeah,
in that first couple of weeks, and then some, but especially in those first couple of weeks. As well, the person's probably in some degree of pain. So pain management is really important to me. So working with the nervous system. So I would say in those early days, I'm really focused on what's happening with the nervous system and lymphatically.
right.
There's no scar tissue that has been formed yet.
Yeah.
So I'm not working with scar tissue, but I might be gently mobilizing layers in a very gentle, non invasive way to keep things from getting stuck.
Like mobilizing in the abdomen?
Yeah, just really gentle kind of work to the person's tolerance and in a way that's not going to interfere with the body's ability to develop a good scar.
Mm. Mhm, mhm.
So that's where the scar wound healing science was really fundamental for me when I took the deep dive into wound healing research. This isn't massage therapy wound healing research. This is the world of hardcore wound healing research.
Right.
And there were two things that basically were the drivers of excessive scar tissue formation. One is excessive prolonged swelling. Two is anomalous tension, so too much tension along the scar margin. And so if the tissue is being distended by a high volume of fluid, that creates a lot of tension along the scar margin. So the myofibroblasts will pull even harder to try to reconnect that tissue. You'll get more collagen because the body's like, I got more, I need more and more because I'm being pulled apart.
Right, right.
And tension can also be created on the periphery by all those things that we know that can create muscular tension or tension and stiffness in the fascial system. So I'm really mindful of those things in the early stages and how to potentially prevent the excessive scar tissue from forming.
Yeah,
As far as the visceral part goes, and this is my personal perspective, I think if you're going to be working with very complex scarring around the viscera, it's really important to have some visceral training.
right, right.
So I have the basics, but I do not have advanced visceral training with Burrell.
Right,
However, I have a colleague in my community that does.
right.
So if someone comes in to see me and I, from my perspective, after an assessment, feel like there's a more complex visceral thing going on, I will refer them out to
Yeah,
my colleague who's had the advanced visceral training.
yeah, yeah. That's good. I think, and that's where we're stronger as therapists is when we have other people that we can work with and that we can help, bring multiple perspectives to our patient
Yeah.
because it's not all about us and like, wow, look at what an amazing job I am doing. It's about is our patient getting better? And so
Yes.
if we can, let go of our ego a little bit to say, okay, this person actually knows more than I do and is able to help in this situation more than I can, and then you can work together. Maybe that person goes over them to them 100%, but often not because you bring something that they're also looking for. And so then you can work collaboratively as a team and bring a really beautiful, comprehensive approach to your patient's well-being. And I think that makes it stronger for everybody.
Yeah. I am very much patient centered.
Mhm.
Again, if you really want to get me off, on a rant,
I
you know,
do.
let, let's
I'll
talk
be
about
flying the ride at the end of the
ego
day.
and healthcare. There's no place for it.
Yeah.
I mean, yes, we all are looking to earn a living, but that whole territorialism thing just never worked for me. It's just I've never came from that perspective. And I will run fast and far from other healthcare providers who come from that perspective. So I made it a real point to get to know who's in my community and who has a practice philosophy that is very much about, I really want what's best for this patient.
Yes.
And if I'm not the person for them to see, then I'll get out there and pound the pavement to see if I can find who is the right person for them to see under those circumstances. And what goes around comes around. So I get referrals from physiotherapists and other massage therapists for people who have more complex fascial things going on,
Mhm.
and scar tissue. So they send me scar tissue people. The physiotherapists do not want to spend an hour
No.
manipulating tissue. Nothing against them, but they
Yeah.
don't want to do that. That's not what they do. That's what we do. We
Yeah.
spend the hour with these, actually touching the tissue and doing things. And the physiotherapists are really great at the things that they do as well. So
Yeah.
I've developed a really great relationship with, a couple of the physiotherapists in my community who send me scar tissue people, new knees, new hips, oncology patients, C-sections, you
Yeah.
know.
And, talking about complex fascia and connective tissue disorders, how do you work with scars with people who maybe they have the Ehlers-Danlos syndrome or they have other connective tissue disorders? All right, folks, that's it for episode 1. I'm going to leave you hanging on that question because next episode, we get into connective tissue disorders and how scars form with that, collagen crimp, radiation fibrosis, sliding and gliding within fascial tissues, products that are good for burns and scars, as well as a little bit around the advanced practice process, which is getting developed for our BC massage therapy professions. So please join us for episode 2, the second half of the conversation. This is Eryn Price of the Mastectomy Guide, signing off for now.